Ahmed, Ghazi. So, I lost your view. Can you introduce yourself? Ahmed is very special for us because he's the future. You know, we wanted so much to have him. I love his work. We all should, and I'm so proud to have him here. And this is real world, and we want him to continue to be the humble man he is, and we believe these rising stars, even if he's already up, we need to support him. So we love you.
Thank you so much. Thank you. Well, that was a great introduction, and hopefully my slides and my presentation can really keep up with that. So, a quick introduction. I'm an associate professor of urology at the Radiological Institute at Johns Hopkins University. I'm the Benjamin Leon Jr. Director of the Surgical Learning and Innovation Center of Excellence and the Vice Chair of Education over there. I started out my education and training actually in Egypt, in North Africa, moved to Europe to do laparoscopic training. Of course, I did open surgery in Egypt, laparoscopic training in Europe, and then moved over to the United States, where I've been for 20 years now, and actually adopted robotics. One of the common themes that I realized in all my kind of journey through urology and surgery is that we have truly a lack in being able to train surgeons in advanced technology. So this is really what the premise of my talk is about. All of us know the Halsted. In Johns Hopkins, we have this huge portrait of Dr. Halsted, who started off by really modernizing surgical education at that point because it was just really a free-for-all. Anybody could train with anybody. He, to some degree, organized it to a residency program, organized it in a way that there is an apprenticeship. And let's be very frank. Surgery is a technical skill that is learned from our experts and is descended down. In this day and age, there are a significant number of procedures, significant amount of technologies. Dr. Thomas just mentioned the evolution of how we do surgery in urology, and this has been really a couple of decades that have seen this change. And so if we don't keep up with training at the same level in which our technology is advancing, we're going to end up in a crisis, which in some specialties we already are. So this is really the armamentarium of surgical training platforms that we have. They are good, but all of them have flaws. You can look at the virtual reality, which I thought was going to be truly the next homecoming of our ability to train surgeons. You can see the warping effect and the lack of fidelity. The problem with trainees, when they believe that something is not realistic, they suspend belief. And when they suspend belief, they start to stop learning. Cadavers are the ultimate anatomical platform. However, they are cost prohibitive and actually unavailable at the moment. And animals, they don't really have the same anatomy. And sometimes we go and pretend to do surgeries that are non-existent. So really, what is the solution? The solution is to truly be able to build something that replicates all the steps of the procedure, is able to be perfused, because we do not deal with patients that don't bleed. They bleed. Right? We need to deal with something that replicates tissue texture because we have become visual surgeons. We really don't touch the end organ that we deal with anymore in most technologies. Replicates complications because complications need to be taught outside the operating room, not inside the operating room. And in some way or fashion needs to have metrics that we're able to judge and also track the progression of the trainees. 3D printing, again, I thought was a solution. It is not the ultimate solution because 3D printing, no matter how sophisticated it is, except in some forms, cannot really produce tissue that is synthetic and conforms to the texture of realistic tissue. You end up with these very hard paperweights. So what we did is we really flipped the coin. We used a molding technique, meaning that we actually, could you advance the slide? I think I'm struggling to do that. Oh, there it is. So what we did is we 3D printed the mold, and then inside this mold, we placed all the structures that we want to replicate. So that allows us to use a material that can replicate the tissue structure of human tissue, but also at the same time, we can put all the structures inside. So this is a kidney. You can see I can place the tumor. I can place all the parts of the kidney inside there and construct them separately. So this is the process. For a kidney or a kidney tumor model, we 3D print the kidney mold, we place all the structures inside it, we inject this hydrogel that is fairly cheap but has been formulated to replicate the mechanical properties of human tissue, and you end up with this organ, which is actually derived from a patient's CT scan. We take that and put it in a body cast to replicate the entire procedure, take it down to the operating room, hang some really dye labeled saline bags, and you can actually replicate this in your OR because it doesn't have one single cell of tissue. So you can use it on patients. This is actually a fairly early prototype where I did the surgery on the model. I also did the surgery on the patient. And so you can look at the similarities between both of these. We've been able to replicate the perfusion, both arterial and venous. We've been able to replicate the tissue characteristics, the difference in the color between the tumor, the fat, the kidney tissue itself. And if the person breaks through or goes deeper than they should and opens the urine drainage system, which is a common thing we do in these procedures of removing a tumor from a kidney, you have to close it up, and you have to close it up watertight. You're also able to close the second layer of the kidney on top of it with the same amount of tension that you need to generate when you're doing a robotic procedure. But one of the things that we realized that since we make such a high fidelity organ, that we don't need to put complications inside. Our trainees have enough ability to create their own complications, but it's complications that come out of inactive decision or something moving in the wrong direction. And you can see here, this is the best way to teach somebody how to deal with a complication because it's in their head now. And once they went through it once with the simulation and in a controlled environment, when it happens in real life, they have that automated response that allows them to get back to that sequence that they have to follow. So this is our radical prostatectomy model. We take a CT scan of a patient, or MRI of a patient with prostate cancer, segment it into different types of structures, all of which are relevant for this procedure, and then we take that and produce a CAD. You'll see here the procedure running in the middle, but you'll also see how we make it. There's a series of molds. There's a seminal, vesical, and prostate mold. And once we make that prostate then goes into a nerve-sparing mold. And if you look at the model in action, even the charring, which is something that's very visual for surgeons, PVA doesn't charge, by the way. We have to add stuff to it to make it black, to make it char, so that the surgeon believes that this is the step that they're doing. Looking back at the molds, you'll see we can place blood vessels, we can place sensors. We then take that and we create a bladder. Bladders are multi-layers, so we create them in hydrogel and multi-layers. We then put that all together to create a structure that resembles most of the structures that you will encounter during the procedure, but then you're also placing it in a pelvis and taking it to the OR. You can see we can create different densities of fat. So this is the posterior plane of the prostate, dense fat. And when you're dissecting this seminal vesicle, there's that fibro fatty tissue. We don't make the entire procedure bleed, but we make relevant parts of the procedure bleed. And you can see how this is also going to be difficult for an expert. So this is not a simulation which an expert will do in 2 minutes. The expert takes about at least half the time that they take for an actual procedure, and the trainee takes more than that. But this is the ultimate platform for them to be able to train. Again, I am an educator at heart. I have a master's in health profession education, and so it makes no sense to build a model that's so great and has such high fidelity without building metrics. And I believe metrics need to be understandable by trainees, because the idea that when you tell them their economy of motion is off, they have no idea what that means. You tell them there's a positive margin that they need to deal with, that they listen to. So if you look at the top left, we put sensors inside the neurovascular bundle, which is the nerve bundle that is responsible for post-operative erection after the surgery. And surgeons have to be very delicate when they handle those. So we put sensors that enables us to detect the ability of tension, the amount of tension they put on it. You can see the trainee down there. They're poking into that neurovascular bundle. They're causing a lot of tension, and the readings are going all over the place. This is actionable feedback. We've also created feedback where we have positive margins. We've placed fluorescence in the prostate, so if they cut through it and leave some of it behind, it'll show up in fluorescence. And we also fill the bladder after the procedure and make sure it doesn't leak. This took a lot of work to make sure that we validate all these metrics, that they are truly differentiating between experts and novices. Moving over to a partial nephrectomy. So this is considered a very difficult partial nephrectomy. And tomorrow's talk, I'll talk about how we use the technology for patient-specific simulation, which is practice of already practicing surgeons prior to a major procedure. Same process. We segment the CT scan to different structures, and then we start making our molds. And our molds, this is all the molds that we use for the kidney. This takes a lot of time to make, about 2 weeks to develop these models because they're handmade. But the result is you're able to replicate all the steps of the procedure. So this is a left-sided procedure. There's a spleen up towards the head. There's a colon that they need to dissect. And you can see we create the hilum, which is the artery, the vein, the urine drainage system, and then put that in a mold that replicates the inner part of the kidney, the medulla, and then replicates the cortex. And you can see even the bleeding itself is replicated here, and this is the most realistic part of the procedure itself. Because even if you do a cadaver, I just came from a cadaver lab that we had, and that cadaver lab over there, nothing bled, right? They were just going through the motions, still a good learning experience, a very expensive learning experience, but there was no bleeding involved. And so we were pretending that it bled. There's no pretending here. This is just a scenario showing you how we set this up in our lab. We have a training robot, and it looks like you are in an operating room with an assistant, just nobody is just wearing scrubs. Well, some people do wear scrubs because the dye, the blood that we use is actually red dye, and it stains their clothes. But this is an actual procedure with all the elements and all the steps involving it in a small closet that is next to our lab. But very importantly, we've realized that the trainee debrief is more important. After we do a robotic procedure, an endoscopic procedure, we tell the trainee, you do want to open up the model? They're like, we can do that. It's like, yes, we can do that because this is a fake model. So they cut open the abdomen and they go in and they inspect the kidney. They inspect their resection bed. They look at the ureter. They look at the surrounding structures, if there's any injury. And then they practice to do a full nephrectomy, which is something that these residents in this day and age in the US actually lack the skill set to do. But you can see it replicates the entire body of the human. It takes a good amount of time to make, but it's very realistic at the end. So how did we reach this level of realism? Well, we did a lot of testing. We had an NIH grant very early on where we got cadavers, fresh frozen cadavers, which is the standard of care, and we measured them in mechanical testing and compared them to multiple formulations of polyvinyl alcohol, which is the hydrogel we use. We did a series of these tests, both functional and both bleeding, and we even used video tensometers. And so this is really the value in which you can elicit out of this. We made multiple other models, hysterectomy models, endovascular models, even a pumping heart. But this is where my passion is, which is teaching established surgeons new technologies. All of you've heard now that we use robotic surgery to do both the donor and the recipient part of a kidney transplant. This is an actual high-risk procedure that requires a lot of training. And so we build a model. We took the CT scan from the donor to get the kidney, and we took the CT scan from the recipient to get the iliac vessels and the pelvis. And we build one model in which they take out the kidney from the top, and then they go down, and they're able to actually place the recipient in robotically. They're even doing this single port now. This is the ultimate training platform for surgeons to be able to do this. And we published this. Got 5 surgeons with no robotic experience, taught them how to do this procedure. And after about 6 months of training, they were able to reach anastomosis times very close to published experts. We also have cholecystectomy and intestinal models that we've made, but this is really my pride. We created a curriculum for single port robotic surgery. That's actually part of that training that I was in. So we created an online curriculum. We got a consensus of 22 experts. We developed an online learning platform because part of a trainee or somebody trying to adopt a new procedure is framing their mind about what is different. So a lot of lectures and a lot of panel discussions and a lot of demonstrations to the models. We then asked the surgeons, what is the difference between multi-port and single-port surgery? And they came out with these basic skills, advanced skills, and procedure skills. And we did this using a 3-month Delphi consensus. We then took all these skills and actually made models specifically to replicate all these skills. You see the B1, B2, these are skill sets that they use to replicate. And we built a curriculum that we ship these models over to their institution, and they train. So there's a model related to access. There's a model that specifically teaches you about retraction, dissection, and being able to flip the single port robot and control the camera, because that's a unique skill to this robot. We then created a model that does anastomosis, end-to-end anastomosis, a tube that they have to cut out a stricture segment, and then they have to suture it together. Suturing in single port surgery is actually very difficult to do because you don't have a wrist, you're using your elbow. And then we created a bleeding platform because you have to use your own suction. And so you have to learn how to use that suction. You have to learn how to retract. You have to learn how to, something that was very simple to do with one robot becomes very challenging to do with another. After they completed this curriculum, we then took them and actually had them do procedural models. And so the procedural models they agreed upon was an extraperitoneal robotic prostatectomy. We modified our original prostatectomy model to comply with single port because not all patients, well, right at that time, not all patients were capable of being done through the single port approach. There's a very common approach that's done through the bladder now, so you don't have to go into the pelvis at all. It's called a transvesical approach for simple and radical prostatectomy. And finally, this is actually one of our proudest models. We deconstructed a kidney procedure to include all elements of it because now there's a new approach known as the low anterior approach. We go from the appendix incision all the way up to the kidney, and the patient is flat on their back. And this is us developing that model, putting it together, and validating it with experts. We even built our own trainer to be able to comply with this. One of the things that we don't teach with simulation, this is the last thing I'm going to talk about, is how do we deal with a crisis scenario. My first 2 aortic injuries in robotics was the first ever time that this happened. And I had no idea what to do. One of them, I was controlling the bleeding, and the other one, I was compressing the bleeding. The vascular surgeon came in. I was like, I have no idea. You have this huge equipment here that you need to move away because I need to make a midline incision. I had no idea what to do, and luckily both patients survived. But I realized that we are lacking in that aspect. So we did a couple of things. We start like any educator does. We asked all the surgeons in our institution, robotics, all the nurses, all the residents, have you ever been trained in a crisis scenario? The answer was an astounding no. We also asked them, how do you want to be trained? They wanted hands-on, they wanted self-paced online. So we built a model that creates this massive bleeding, right? And this massive bleeding is what is the crisis scenario that we're trying to solve. We then created a scenario where we talked with the company in a way in which we can take our training robot and fault the device. Now, this is not a fault related to a stapler. I have to say this several times. Their stapler works. We are the ones that made the stapler not work. So the stapler cuts, but does not staple. So that's a crisis event. And here they're stapling across a pedicle. They have to go in, they have to make an extra incision on the side, put their hands in, be able to control the actual bleeder, and then remove all these instruments, and then they can convert into that procedure. The results are very clear. The surgeons that did it the first time before they got trained had an extensive amount of blood loss and an extensive amount of time to convert, while after the curriculum, there was a significant decrease in both of these factors. Thank you very much for your time. Questions?